Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus. I'm also a family physician at the Gateway Family Health Clinic in Moose Lake. I'm your host for our program tonight on infectious disease and immunizations. The success of this program is very dependent on you, the viewer, so please call in your questions tonight or email to ask@wdse.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening are Dr. Mrna Tyner, an infectious disease specialist with St. Luke's Infectious Disease Associates, and Dr. Addie Vittorio, a family physician with St. Luke's. Our medical students answering the phones tonight are Barrett Bukowick from Warroad, Minnesota, Andy Cable from Danube, Minnesota, and Emily Clark from Ivanhoe, Minnesota. And now on to tonight's program on infectious disease and immunizations. Welcome, both of you.
Thanks. Thank you.
Addie, great to see you again.
Yeah.
Can you tell us a little bit about your practice and what you do?
I'm a family physician. I work at 2 different clinics amongst St. Luke's, so the Mount Royal Clinic near the university, and then also the Lester River Clinic out furthest east off of 61. And I see a variety of patients day to day, all the way from birth up to sort of elderly age. We treat both sort of acute things like coughs, colds, other things that may come up, as well as make sure people are healthy by giving them immunizations and doing our routine well child and well adult visits.
Great. Dr. Tyner, tell us a little bit about your practice life.
I see patients inpatient and outpatient every day. Inpatients that I see, people in the hospital, are the ones who have kind of complicated infections, so prosthetic joint infections or bloodstream infections or mysterious infections. Infectious disease, people get to kind of answer the mysteries or kind of dig into difficult things. And in my clinic, I follow patients with long-term infections such as HIV and hepatitis C, and also see people when they come back from traveling and might have unusual things or might be preparing to travel.
Thank you. I think a good place to start is probably with flu, the good old flu. It's that time of year and the flu shots are being talked about. Addie, are you seeing influenza yet in your office?
We are actually not seeing influenza being diagnosed. We do test for influenza frequently when we test for Covet or other childhood infections, but we really haven't seen a spike in cases as of yet. It's still fairly early. I think in this area we've seen the flu pop up, kind of around the Christmas time, but also peaking in February and March in our spring months. We are vaccinating people right now in our clinics for flu, and there are a variety of vaccines available for different age groups. But it's a good thing to start getting vaccinated for the flu now.
Dr. Tyner, I lost my train of thought on this one.
I think I know where you're going with that.
Yeah. With the influenza and with the virus out there, what are you as for St. Luke's, where I was looking for was with the big system, are you seeing any flu in the area, or because we've got you isolated in your clinics? So from a bigger standpoint, flu?
Not that we've seen a whole lot of. We are testing for it regularly as well. I'm not aware of a case yet in our county. I haven't looked recently, but I haven't heard of a new case in our county. But we are also offering the flu vaccine, and as like Dr. Vittorio was saying, there's a lot of different flu vaccines out there. There's some common misconceptions about who should and shouldn't get the vaccine. People who are concerned they might have an egg allergy. The good news is that even if you have a history of an egg allergy, a real egg allergy that prevents you from eating eggs, it's still safe to get most flu shots. And there's actually ones that are made without using eggs, and there's a variety of other concerns too. There's very few reasons not to get a flu shot. They're safe, and they are effective at preventing against infection that causes death.
Well, it's interesting that you bring up the egg allergy, because there are a lot of people who are just no.
Yeah.
And it's not only for the flu, but for other vaccines also.
It's true.
Yeah. Do you see quite a bit of pushback?
And I think that's one of the roles as a primary care doctor. It's my role in kind of being the first line to talk about the risks or the benefits to getting the vaccine, and to sort of be able to give not political advice, but more sort of sound medical advice of what we know about vaccines and what we know about how they can prevent disease. if you look back in medical history, they're some of the most sort of the greatest things that have happened in medicine so far in this century and the century prior. So,
Couldn't agree more.
I don't really want to go down the COVID line too far. We've done that a lot this last month already. But there is the question, how far, we talked earlier, we can give a lot of shots at once or they need to be separated. The big one is coming up right now because the COVID booster all of a sudden is coming out at the same time we're trying to give the influenza shot. So what's one to do? Harmony, I'll put that in your lap.
Sure. It is safe to get the COVID booster or any COVID shot at the same time as an influenza shot. You can actually get many shots all on the same day, but if they're not given on the same day, you should wait 2 weeks to get your shot. So if you get the COVID booster but didn't get your flu shot, wait at least 2 weeks before getting your flu shot, but it's also safe to get it on the same day.
There's a question, we've got a lot of questions coming in and we'll do our best. Last year we had a pretty flat flu season.
Yep.
And at this time this year we really don't know. So far I haven't seen much. It seems like there's fewer flu cases this year than in last year. Is this because we've been wearing masks? Should we keep wearing masks during future flu seasons?
I think that's a good question, but it's also something we did see last year. We saw a lot less flu last year. And some of the speculation, we haven't necessarily been able to test this, is that we were wearing masks, we were staying home when we were sick, we weren't going out and exposing other people potentially to our illness. And in other countries, such as Asian countries, when you get sick, you wear a mask or you don't go out, you don't go to work. In America, that didn't sort of historically happen until more recently with the COVID-19 pandemic. And I think it's great advice that when you're home or when you're sick, you stay home. You don't go to work when you're obviously sick, and that we wear a mask when we're potentially putting others at risk.
I think the second half of that question was about who should be wearing a mask right now. And the CDC actually recommends that everyone be wearing a mask right now, especially if you're in a public place indoors within proximity to other people.
And we know in Minnesota that that's all winter long.
True, and these infections are aerosol spread pretty much, especially COVID.
Yes.
So yes. Do you increase in flu cases this year?
Anticipate an increase?
Yeah.
I think that really depends on how people behave and sort of what we actually see with the strains that are out there this year. And we know very little right now this year because we haven't actually seen this worldwide or locally yet.
Why do some people have such serious side effects with immunizations and others don't? And Addie, do you want to tackle that first from a primary care standpoint?
Well, I think immunizations are designed to stimulate an immune response, and that is the purpose of an immunization, is to stimulate our bodies to produce antibodies so that if we're future exposed to something, we can mount an immune response that's more robust than having not been exposed to it before. And so there are genetically likely people who respond sort of immunologically more robustly to vaccines, to allergens, to diseases, more so than others. So some of this may be genetic. It may also be based on their previous exposures to things that are similar or that have reacted similarly in their systems.
Are there any vaccines other than tetanus that should be updated every few years? And have a go at it, either one of you.
It depends on the person, actually. Tetanus is a great example. Some people who don't have a spleen should get more regular boosters of different vaccinations. For example, the meningococcal vaccine they should have more routinely. There are different vaccines that are due at different ages as you go along. So when you hit a certain age, you should get the shingles shot, and when you hit a certain age, you should get a pneumonia shot. So there are vaccines that kind of come up. So once you hit 18, it's not like you're done getting shots, or annually, like the flu shot. So there are some that do recur, but it depends on the person. We mentioned this before too. There's actually over 80 vaccines that have been approved by the FDA, and we don't recommend all of them for everybody, but everybody's different, and everybody has a different immune system and different risk factors. So,
and many of those vaccines can be used in people who have had allergies to other vaccines in the past.
That's correct. There are some very specific exceptions. So if you've had a severe anaphylactic reaction to a specific component of vaccines, we would look at the particular vaccine to see if you're at risk for that as well. But that's extraordinarily rare.
And I think we kind of miss some people who may be at risk and need more vaccines. But for an example, anyone with a lung disease such as asthma, or even a heavy smoker, or someone with smoking-related lung disease, heart disease, we recommend throughout adulthood actually vaccinating for things like pneumonia routinely every 5 years.
Question for you, Harmony. This person's had a splenectomy. Will not have, we already started on this, so maybe we want to just bring this out a little more. Will not having a spleen increase my risk of different infections?
Yes, specifically yes. So we know that the spleen is particularly effective at clearing your blood from bacteria that have a gooey capsule around them, and there are vaccines designed to protect you against those. The vaccines include Haemophilus influenza, but the meningococcal vaccines and the pneumococcal vaccines, and we do recommend having those vaccinations done. So if you don't have a spleen, you are at increased risk, and we oftentimes will actually recommend that you carry an antibiotic with you as well if you don't have a spleen. So yes, you should see someone for vaccinations for that.
I heard Shingrix come up a little bit ago too. Addie, talk to us a little bit about Shingrix and why a person should get it.
Yeah, so
and when.
Shingrix is sort of our second generation shingles shot. One came out several years ago, which many people may have gotten. That was considered what we call a live vaccine. The new vaccine out for shingles that is recommended is called Shingrix, and it's not a live vaccine. So it can be given to immunosuppressed persons and persons who are living with immunosuppressed persons. Shingrix protects against the childhood disease varicella or chickenpox, but as adults that actually lives in sort of a component of our back, in the nerve cells. And so if you get sick physically, even mentally stressed, shingles can actually come out in the form of an itchy, painful, awful rash that occurs on one side of the body in particular. And so there are recommendations for persons who've had chickenpox and persons who've not had chickenpox to be updated for the shingles vaccine when they reach age 50. And that's a 2-part series, so it's given initially, and then 6 months later a booster dose is given. And what we've seen with the new shingle shot is that it's very effective against shingles versus our older shots, which were somewhat more marginally effective against shingles.
Yeah, I agree. It's been a good immunization. I hardly get sick. Why should I get a flu shot?
I think part of that is if you hardly get sick, think about the others around you, and that even if you're a person who minimally gets symptoms, just as we've seen with COVID, you can pass it around to people who are near you who may be more at risk.
Not everyone's going to get influenza every year, and having the flu shot will reduce the severity is likely to reduce the severity of your infection. It's a moment of a shot, but getting an actual influenza infection can knock you down for over a week.
Well, influenza is not without risk either, is it?
Definitely not.
I forget the numbers, but there's a death rate that's fairly significant. It's not as bad as COVID, but it's there.
Definitely.
So there's good reasons to look into
And I think
that.
both Harmony and I have probably seen people in the hospital who you wouldn't necessarily feel are at risk for influenza who've done, surprisingly very poorly with influenza.
Yeah, we
as well.
certainly see in non-COVID years, I see people die from influenza every year. I hate to say blanket statements, but I cannot think of a single one who was vaccinated who passed away from influenza that I've taken care of.
And that seems to be the thread that's running with COVID also. Immunization is quite protective. What practices implemented during the COVID pandemic will persist after the pandemic is over? It's an interesting question. And I've mulled on it a little bit as I think about it. So I'm wondering, am I going to be wearing a mask and goggles in the office? Because I think about the size of the office, air exchange, and all of the other factors. Are there things that are going to persist? Are we going to see better air exchange systems?
I don't know. I don't know that we've, proven the air exchange is sort of the go-to for this. I think we've proven that if you stay home when you're sick and you protect others by having some sort of barrier, those things may stick. I would hope that employer sort of practices would stick a little bit regarding sick days and working from home, but again, not sure in America if that will stick either.
I really hope that through all this we learn how to be kinder to each other. I hope that sticks.
Yes. And then the importance of public health versus my personal beliefs. And that's a tough one. I'm getting knee surgery soon. How concerned should I be about getting exposed to bacteria and viruses at the hospital? Harmony, I'll turn that one to you.
So one of the interesting things that's easy to forget is that bacteria and viruses are everywhere. The world is covered in bacteria, and anyone who has me over as a dinner guest knows that I love to say the world is covered in poop, because it really is. It's just everywhere. These germs are everywhere, in your environment, in your home, on your skin. Yes, they're in the hospital as well. How much are you at risk in the hospital versus outside of the hospital? There can be more resistant germs in the hospital. The things to do while you're in the hospital are the same things you would do at home. Wash your hands, bathe, and follow your doctor's recommendations. They may ask you to do a body wash ahead of your surgery, and that's a good idea as well. How concerned should you be? About 1 to 3% of all joints become infected during surgery, so 1 to 3% is how concerned you should be.
Thank you. Addie, what immunizations are considered essential before going to college?
Well, as a family doctor, I would say your childhood vaccines would be important. However, the most important thing probably is to think about what you'll be doing in college. And so the majority of people either going off to the military or going off to college are going to live with 1, 2, 3 or more people. And so when you live in close quarters, we do recommend that you update your meningitis shots. And meningitis is given at the age of 11 to 12, and then a booster dose is given between age 16 to 18. And over the past couple of years, we've actually developed a second meningitis shot. So there's 2 different types, and the meningococcal B is sort of the newer type, but we recommend 2 doses between 16 and 18 for that. Those are probably the most important outside of getting a tetanus shot every 10 years, and then making sure your other immunizations from childhood are updated. Obviously, we're not at risk for some of the severe infections that infants see, but we're certainly always at risk for polio when we live in close quarters with people, and some of the other things we vaccinate routinely before going to school.
Why does our tetanus shot have to be a DT or whatever it is now, Harmony?
So tetanus can sometimes be paired with, it's pertussis. You're going to ask me about diphtheria and pertussis.
DPT,
There's the DTaP.
So you usually don't
Tdap,
just get one, you get all 3 now.
It's usually tetanus and diphtheria together. Why does tetanus wane? Why does the immunity against some vaccines wane? I don't know the answer to that question. It's a really good immunologic question. Our immunization wanes, and it's good to be boosted. It happens.
And I think if you're exposed to pertussis, and who's at risk for pertussis, what we see are outbreaks in this area in school age and middle school age kids tend to pass around pertussis. Pertussis is in older people, older being over the age of an infant, results in a severe, uncontrollable cough, often for weeks and weeks at a time. Vomiting after coughing is very common. And so persons exposed to children in those age groups are at risk. And so I recommend most parents or grandparents try to get the Tdap, which has the pertussis in it.
This is an interesting question, and either one of you can go after it. I was thinking about putting a dryer sheet in my mask to provide a better smell. Is it harmful for me to breathe that in?
I think it's probably less of an infectious disease question and more of a toxic exposure question.
Yeah.
I think they're pushing it your way, kind of.
Yeah, so
I agree with you.
anything we smell involves a volatile compound that sort of goes into our nose, and a lot of times if it's a commercial product, it can be a chemical or some sort of compound that may not be great for us to be in close quarters with.
I agree with that.
Why do some people have, I think we've already talked about this, such heavy side effects with some of the COVID vaccines? And I guess we kind of discussed that we all react a little bit differently to them. So there's a question in here about the different types of COVID vaccines. Do you want to briefly just discuss those? Maybe Harmony, that falls in your purview.
Sure. Currently, in this country, there's 2 different kinds of COVID vaccines. The one that we kind of hear the most about are the mRNA vaccines, which are basically a tiny bit of RNA, which is a messenger piece of genetic material that tells your body to make a protein, that protein then goes out and is recognized by your body. This protein is presented via antigen-presenting cells to your B cells, which then recognize it and then make antibodies against it. That genetic material is kind of like cotton candy. It evaporates almost immediately after it's recognized, and those proteins are treated like every other protein in your body, and they rapidly disappear out of your blood as well. They don't stick around. And by presenting this antigen to your body, you make antibodies. That's the mRNA vaccine. The Johnson & Johnson vaccine is a more traditional vaccine, and instead of using a genetic piece of material to teach your body to make that protein, it just gives you the protein. Almost identical mechanism of producing antibodies, just that one step is different. They're very similar in actual practice.
Back to shingles. We've got a couple of shingles questions. The first one is, I've had shingles and have not had the vaccine. Will getting the vaccine be helpful for me after I've had shingles? That's one. And I've had shingles twice. Do I still need to get the shingles vaccine? So kind of pull those together.
So kind of two parts, or kind of putting that
Yeah.
together, is once you get shingles, you're actually likely to get more outbreaks as you go along. So you're certainly more at risk than sort of your friend who's maybe never had shingles before. And there is a point where, yes, when you get shingles and it kind of presents itself to the body, you will get some antibodies, but they don't last forever. And we don't really know sort of the amount of time, but we still do recommend, even after having multiple episodes of shingles, that you be vaccinated. And we definitely see less outbreaks after vaccination.
This person had a COVID booster 45 days after breakthrough COVID infection. I heard you are supposed to wait 90 days. Are there any harmful side effects with getting it sooner? And we kind of chatted about this before.
We did. There's not any risk to getting it sooner. The original rationale behind 90 days was because there was a relative shortage of vaccine. We don't have that anymore. We presumed that people who had infection probably had at least 90 days of immunity before their immunity would wane to the point they would need vaccine. There is evidence now. There's a New England Journal article that came out several months ago that suggested if you did wait a month, 2 months, up to 3 months, the amount of immune boosting you would get might be larger, but it's not going to cause any harm to get it sooner than that.
There's a question asking us to elaborate more on the CDC warning on myocarditis in adolescents and young adults, especially after the second COVID vaccine. I'm not aware of this one, so I don't know anything about this.
We were talking about this before we came on, actually. So myocarditis does exist, as we've talked about, and it is a vaccine side effect. The risk is extremely low, but it is something that an otherwise healthy person who gets a vaccine can experience.
We also know that myocarditis is a complication of COVID infection itself, about 15-fold higher if you have a COVID infection to get myocarditis, or 15 times more. Other viruses can also cause myocarditis, but we have seen, as a side effect of vaccination in otherwise healthy people, a slight increase in myocarditis. It's not zero.
We talked earlier, Harmony, you and I, a little bit about risk factors for vaccines. Do you want to elaborate? We talked a little bit about travel and things that you look at and maybe people should think about.
Yeah. So, like I mentioned, there's over 80 different kinds of vaccines out there that have been approved by the FDA. We don't recommend them for everybody. There's yellow fever and cholera and dengue for people who are traveling. There are vaccines for people who are going to be living in congregate settings, like going to college, and who don't have spleens or who have HIV. Whoever has an immune risk or has a chronic disease like chronic kidney disease or chronic lung disease could consider having a vaccine visit to see if they should be vaccinated against any additional infections.
This past summer, tick diseases or not, Addie?
I've actually seen quite a few tick-borne diseases, even late in the fall, so within the past couple of weeks. And strange presentations of tick-borne disease, getting just one single rash or getting a whole body rash that looks nothing like a Lyme rash. So if you have exposure to deer ticks or ticks in general, or you have symptoms that may reflect tick-borne disease and you have the risk of being an outdoors person, it's worth seeing your doctor and getting evaluated and potentially checked for those.
Are you seeing an increase in the common illnesses this year versus last year, now that people are mixing again?
I think so, but I think the other thing is last year we didn't see people when they got common illnesses. Most people were kind of staying out of the hospital, staying out of the clinics, and this year we're seeing people access the healthcare system because they either feel more comfortable or we've initiated practices that make it easier to do so. So I think we're just seeing more people in general.
We're basically out of time, so I'm not going to push another question at you. But thank you very much for a very interesting program. There was a lot of information that we went over this evening. I want to thank our panelists, Dr. Mrna Tyner and Dr. Addie Vittorio, and our medical student volunteers, Barrett Bukowitz, Andy Cable, and Emily Clark. Please join Dr. Mary Owen next week for a program on stroke and other neurologic problems when her panelists will be Dr. Vikram Jadhav and Dr. John Wood. Thank you for watching. Good night.